So jump right in my disclosures. So this was reviewed already, just some basic concepts to get everyone on the same page. So we have a new definition now of steatotic liver disease, starting with steatosis. Very simple, based on imaging or histology. In more than 4% steatosis, that's abnormal. We have a diagnosis of steatotic liver disease. Next, we look for the presence of at least one cardiometabolic risk factor of any of the 5 listed here. And then, once we find that, we move on to quantifying alcohol use, which has become even more important now since we have a new category, which we'll talk about. So, less than 20 to 30 grams of alcohol per day for women and men, respectively, that will be considered MASLD. Anything above 50 or 60 grams of alcohol per day for women and men, that's alcohol-associated liver disease, or ALD. And anything in between is what we now call MAT-ALD. So it will be an overlap between both metabolic associated steatotic liver disease and alcohol-associated liver disease. However, as simple as it sounds, quantifying alcohol consumption is not easy. And right now, we mostly rely on interview or self-report from patients. There are pros and cons, I should say, starting with the pros. It can be quite powerful if we have the time and are able to do that in depth with our patients. The advantage of relying on history is that we can go as far back as patients can remember, 10, 20, 30 years, as opposed to alcohol biomarkers, which will also only give us information in the preceding days or weeks. And if well done, it may help us establish a rapport with our patients and decrease the stigma and the sense of disapproval they may have overall. However, as physicians, I don't think we have enough training on how to obtain adequate alcohol history. We may sometimes use language that is inadequate and may actually turn off our patients. And we obviously have limited time. And to get an adequate alcohol history, we need to have enough time to inquire our patients at length. From a patient perspective, we know this. There's data showing that patients often underreport their alcohol use. That may be due to stigma or just that they can't remember. And finally, at a system level, to get more complicated for us, is that drink size and quantity of alcohol used varies from country to country and even within country. Just use an example, beer for example. Now we have craft beers that have as much as 10, 12% alcohol. And we have different bottle sizes. So asking the patient how many beers a day they drink is not sufficient. You need to know what kind of beer, how much alcohol is in it, what's the volume. So that becomes more complicated for us. We need to quantify grams of alcohol per day that our patients are drinking. So this to illustrate this example, how much is just one drink? And it's dependent on alcohol content, percentage, and volume. So we need to be able to quantify that with our patients. A glass of wine may be different for everyone. So we need to know what's the volume and what's the alcohol percentage. And as I mentioned before, we know that patients underestimate their alcohol consumption by as much as 40%. Whether it's intentional or not, we know that that is a fact. And also to complicate things, what's the definition of a standard drink varies from country to country. For example, in the United States, one standard drink equals 14 grams of alcohol, whereas in the UK and Barcelona, that's 10 grams of alcohol per drink. So what about alcohol biomarkers? Probably my favorite biomarker right now is PATH, or phosphatidylethanol. And we're very fortunate that we have this available to us in-house. So it's a test that we can do, it's a blood test that we now do routinely in all our patients with steatotic liver disease when they come to see us in clinic. PATH in the blood actually can reflect alcohol consumption as far as back as 28 days or 4 weeks. So that's the longest we can go with routine tests in clinic. And we know that the level of PATH in the blood may actually tell us how much the patients are drinking. Less than 20 nanograms per ml indicates abstinence or minimal use. The levels between 20 and 80 indicates maybe 1 to 2 drinks per day. So according to the new definitions of steatotic liver disease, these levels will fall within the MASLD category potentially. Levels between 80 and 200 may indicate 2 to 4 drinks per day. Now we're getting to the MAT-ALD category. And anything above 200 indicates more than 4 to 5 drinks per day. And now we're getting to the ALD category. So this can potentially be helpful if the level can tell us how much drinking the patients have been doing, with the caveat that it's only the past month. So patients consume alcohol at different levels throughout the year. Assuming that the alcohol consumption is constant, to be able to use this to make a diagnosis of MAT-ALD or ALD. And the limitation of PATH, specifically of blood transfusions. And there are several case reports now that have shown positive PATH levels that actually reflect alcohol consumption from the blood donor, not the recipient, because it's a blood test. Just to illustrate the impact of PATH, so this is a study I really like from one of my prior trainees at Mayo Clinic. He looked at PATH levels in patients with cirrhosis being evaluated for transplant. He had about 300 patients. He compared the PATH level severity, which I just mentioned, with self-report. And in this study, in simple terms, he found that 60% of patients underreported their alcohol use when confronted with PATH levels. So PATH levels are much higher than what the patients were telling the doctors. And this was a liver transplant clinic, in a liver transplant center. And even more alarming, you can see that 20% of patients that had heavy drinking detected on PATH levels reported no alcohol use or light drinking. So 20% of patients are really under-reporting their alcohol use or simply just not telling us the truth. So moving from PATH to another test that we have available, which is the ethylglucuronide. So ethylglucuronide, or ETG, can measure both in the urine or in the hair. The hair ETG, unfortunately, is not clinically available. The urine is, but the urine test only reflects alcohol use as far back as 4 to 5 days. The hair one is better. This can reflect alcohol use up to the preceding 3 months, but it's not something, at least in the US, that is clinically available yet. Hopefully it will be, because it may reflect more prolonged use. There's also limitations with the urine test. Urinary tract infections, bacterial contamination can impact the results. And for the hair ETG, hair dyes and conditioners can also lead to false negatives. All right, so alcohol biomarkers are good, but not great, because again, they only reflect recent use. I think we need to start thinking now, especially that we have a new category, and we're going to talk about the impact of alcohol use in steatotic liver disease in general, to have novel clinical and laboratory biomarkers that can guide us without relying on alcohol biomarkers or medical history. So this is an example of a tool, a score, that was created by us at Mayo Clinic many years ago. And for those of you who are interested, we have a calculator that is still available online, and that is the link there down the bottom here on the Mayo Clinic website. But it was a very simple calculator that was created before MAT-ALD even existed. And it was a binary score that was supposed to help us determine whether patients were more likely to have MESLD or ALD. And very simple parameters, things that we know, right? So high MCV, male sex, low BMI, and high AST to ALT ratio were all associated with a higher likelihood of ALD compared to MESLD. So a very simple calculator relying just on clinical and laboratory tests that could guide us one way or the other. Now, the reason I mentioned this was created to help us differentiate the two and sometimes confront patients if the self-report alcohol use is not congruent with what we're seeing in clinic. But I wanted to point out that the score performs really well at the extremes. However, there's a mid-range here that the model does not perform as well. So ANI score between -5 and 5, the middle zone, I would say, the accuracy of the model is not great. And I hypothesize that this gray zone here in the middle between the ALD and the MESLD might actually represent MAT-ALD. It's just something that we were not thinking about at the time yet. So now we're in the process of reanalyzing this and creating a new score that maybe has 3 categories that can help us distinguish between the 2 extremes and the 1 overlap in the middle. And I want to point out before I move to management, one of the main limitations of the classifications that we have now for steatotic liver disease. This is a great study, one of my favorite studies so far, looking at MAT-ALD, is that the thresholds that were chosen for MESLD, MAT-ALD, and ALD with regards to alcohol use, as I mentioned before, are arbitrary. Those were chosen arbitrarily. They are not evidence-based. So we need studies to show, are these thresholds appropriate? Are we just labeling MAT-ALD when in fact these patients may have ALD, or many patients with MASLD could have MAT-ALD? And this is an example of that. So in this study from Marta Aguado and colleagues from Barcelona, they looked at more granular alcohol consumption in a large prospective cohort of patients. And you can see they have the two categories down here, which are based on the current thresholds of steatotic liver disease I mentioned before. But then they looked with patients that were classified as MASLD, those that consume moderate amounts of alcohol use, but not high enough to be in the MAT-ALD category, had significantly higher risk of fibrosis that was quite similar to those with MAT-ALD. So you see how they behave more like these patients than these patients. So looking at this data, the way I interpret this, the way I see this, is that maybe the thresholds that we have for MAT-ALD right here are too high. And maybe they should be down here. Maybe the 20 to 30 grams of alcohol a day are actually higher than we should consider for MAT-ALD. And I think the danger of having these thresholds being arbitrary as they are is that if you label a patient with MASLD, and we just heard many studies looking at MASLD, we may not be paying attention at how much alcohol they use, or we're not being as aggressive as we should be at treating the underlying alcohol impact on their disease. So more studies like this are needed for us to understand what is the ideal threshold, what's the safe line to separate MASLD from MAT-ALD and then ALD. All right, and to emphasize the importance of that is that the impact of alcohol in steatotic liver disease is quite significant. As we know this already, but this study shows it really well, that ALD has the highest rate or risk of hepatic decompensation, and also the highest risk of mortality, second by MAT-ALD, and third we have MASLD. So alcohol-associated liver disease in the setting or the absence or presence of metabolic dysfunction definitely leads to a higher risk of complications and mortality. Again, emphasizing the importance of us paying attention to the impact of alcohol in these patients. All right, so moving on now to treatment options in steatotic liver disease across the spectrum, from MASLD to ALD. This is a nice figure from a review paper from our colleagues in Spain as well, where you can see the different options that we have currently available and the ones that might be upcoming. And you can see the overlap. MAT-ALD is in the middle, and those are the patients who will be targeted with both metabolic dysfunction-directed therapies, particularly weight loss, physical activity, and those in the ALD category who benefit from alcohol use disorder treatment. So before I go into the ALD treatment, focusing on AUD, I want to touch on a couple of drugs that are quite promising in the MAT-ALD. So to be clear though, we do not have any published trials yet, for therapeutic trials I should say, for MAT-ALD. We have a lot in the MASLD, we have some coming still coming in the MASLD, and some being started in MAT-ALD. So it's still a large unmet need. I will point out, I won't show this, but there was resmetirom, the Maestro trial that was published in the New England Journal of Medicine. The authors went back to see how many of those patients, based on the definitions of steatotic liver disease, had MAT-ALD. This is unpublished data, but they presented at the liver meeting just this past month. And about 10% of patients in the Maestro trial with resmetirom actually had MAT-ALD. And they did a subgroup analysis, and they found that resmetirom was equally beneficial in those patients with MAT-ALD. Even though nobody addressed the alcohol use, resmetirom also led to a 30% reduction in fibrosis and NASH resolution in those who will be classified as MAT-ALD in that trial. So it's unclear whether resmetirom will be beneficial in those patients or not, so more studies are needed. But I want to talk about GLP-1 receptor agonists. A lot of excitement in these drugs also being effective in treating patients with alcohol use disorder or patients with MAT-ALD. There's one small trial that was published showing a potential benefit in reducing heavy alcohol use in patients who were obese. And then came this study. So this is a retrospective observational cohort study published in Nature Communications just recently, using a large EHR data from the US, over 100 million patients in that retrospective cohort of patients, and they found 27 patients who received semaglutide for treatment of obesity, And they propensity matched those patients with 27,000 patients who were receiving other anti-obesity drugs. And you can see here the top line overall result is that there was a 50% reduction in the new diagnosis or incidence diagnosis of alcohol use disorder in the subsequent 12 months. So basically, patients that received semaglutide were less likely to develop an alcohol use disorder in the future compared to patients that received other drugs to treat their obesity. So this is kind of a signal that maybe GLP-1 receptor agonists may actually lead to reduction in alcohol use and prevent development of alcohol use disorder. In the same study, they also looked at other outcomes of recurrent AUD and showed the same effects. And the effect may actually be even stronger in patients with type 2 diabetes, where you see a 70% reduction in the risk of alcohol use disorder. Oh, and if you ask how this might work, we actually have GLP-1 receptor agonists in the brain, specifically the dopamine reward system. So by activating those receptors, it appears that we don't get the same rewards when we drink alcohol. So people are less likely to enjoy drinking alcohol, they're more likely to decrease their alcohol consumption. At least that's the theory, one of the theories. And the other promising drugs or class of drugs are the FGF21 agonists or analogs. So there's no human data yet with these analogs. However, the preclinical data is very promising. So this is data from Cell Metabolism published 2 years ago. They used primates that actually enjoy drinking alcohol just as humans. And they gave alcohol to these primates, for 4 hours a day, whatever they wanted to drink for 4 hours every day. And half the animals received a placebo, the other half received an FGF21 agonist. And you can see that animals in red here that received the FGF21 analog have decreased in their alcohol use from baseline during treatment at 2 different doses. And then that consumption increased after the drugs were stopped. There was no difference on the amount of alcohol, volumes of, water consumed. So what we see was a decrease in alcohol consumption and a decrease in water drinking. So it appears that the animals did not enjoy drinking as much alcohol when they were receiving FGF21 agonist. Similarly, it appears that FGF21 acts in the brain. They found specific neurons in the amygdala that are sensitive to FGF21 that appear to help decrease the amount of alcohol drinking in primates. So this is promising. FGF21, as you know, has been investigated in MASLD. It helps decrease lipogenesis and increase fatty acid oxidation in the liver. So this is kind of a bonus, a benefit of FGF21 that can help steatosis, but they also help decrease alcohol consumption, similar to GLP-1 agonists. All right, so now for the last few minutes here, I want to touch briefly on ALD specifically, and the importance and the benefit of alcohol abstinence. I don't think I need to emphasize this too much. It's pretty well known now that abstinence from alcohol leads to better outcomes, specifically in early stages of liver disease. So this is an old study now, but just highlighting that both in patients with compensated and decompensated cirrhosis, you can see that abstinence leads to better survival at 10 years, and it's only better in those who are compensated than those that are decompensated. But it's never too late to stop drinking, that's what I tell my patients. Now, to achieve alcohol abstinence, patients need to receive treatment for their addiction disorder. And this is a study from the VA system in the US as well, where they looked at the impact of any AUD treatment, whether it was behavioral therapy or pharmacotherapy, it didn't matter, but they found that patients that received some sort of AUD treatment were less likely to decompensate, 50% almost reduction, and also less likely to die, both in the short term and the long term. And they did not look at how many patients achieved abstinence, they did not have that data, but they only looked at whether they were prescribed any AUD treatment. So just being prescribed AUD treatment appeared to already have led to better outcomes. And this other study from the US as well, the Mass General Group, published a couple of years ago, looked just at pharmacotherapy. As hepatologists, we cannot offer behavioral therapy. We are not trained psychiatrists, but we can prescribe drugs that can help patients quit drinking. So if you want to know what's the benefit of drug therapy for AUD, this is it. you can see that patients that received NAOD treatment were less likely to decompensate at 10 years. So the risk of decompensation was 25% compared to more than 50% in those that did not receive AOD treatment. And the median time to decompensation in those that were untreated was 2 years compared to more than 6 years with those that were treated or received AOD treatment. And we do have 3 FDA-approved drugs to treat AOD. 2 of them that are safe to use in patients with liver disease. So acamprosate, which can be 3 times a day or 2 times a day even, and naltrexone, which is once a day. So they're easy to prescribe. I prescribe them routinely in my practice, but unfortunately, I'm a minority. So this is a survey study done by the Alcohol Interest Group in the US from the AASLD a few years back now. And we surveyed hepatologists across the country. We got 408 responses from 33 states. And we learned that 2/3 of hepatologists have never prescribed either acamprosate or naltrexone for their patients. And half of them reported that they haven't prescribed because they lacked knowledge on how to prescribe these drugs. The majority of hepatologists do want to be trained and want to learn how to prescribe these medications, which is great. So we need to be doing better at teaching our colleagues how to prescribe these drugs ourselves. And the reason I prescribe myself, I do refer my patients to psychiatry to get behavioral therapy. I don't wait for psychiatrists to see them and prescribe drugs, because many of my patients, at least in my practice, do not go to their appointments with psychiatry because they know they're going to be talking about the alcohol use. They don't want to do behavioral therapy. They don't want to be labeled as having a mental health condition, but they're likely to take a medication, take a drug, if I prescribe to them. So that's the minimum I can do to help them. And finally, the ultimate treatment for ALD and not ALD, especially advanced stages, is liver transplantation. And this data from the US, just published as well from UNOS, you can see that the number of transplants in the US is increasing every year, but that is at the cost of ALD. So in blue here, a patient with ALD, in the last 5-10 years, that's where we see the most increase in transplants in the US. And in red are patients with alcohol-associated hepatitis. We're doing more and more of those as well. We're doing early transplants for patients with severe ALK-HEP that unfortunately cannot wait to get treated and sustain abstinence. And as I mentioned before, we are doing more and more early transplant for ALD. So this is the Dallas Consensus that was published a few years ago from the US. This was initially developed to help us assess patients for early transplant in the setting of severe ALK-HEP. We use this criteria now for any patients with severe ALD and high MELD scores that cannot wait for a liver transplant. So I'll just have it here for your reference, and this is what we use in our practice to allocate transplant. So in conclusion, diagnosis of MAT ALD relies, as I mentioned, on accurate measure of alcohol consumption, and unfortunately, the best tool we have is self-report. The self-report is not great. Underreporting is common. Half to 60% of patients underreport their alcohol use due to stigma or impaired recall. Alcohol biomarkers are helpful, but remember that thresholds are not quite known yet for MAT ALD, need to be validated, and also they only reflect recent alcohol use. So we need to be investigating clinical and biochemical markers of MAT ALD, and I encourage the investigators in the room to tackle this as well. The distinction, as I mentioned, between MASLD and MAT ALD is based on arbitrary cutoffs for alcohol use. Personally, I think those cutoffs are too high, and there are many patients with MASLD that are drinking too much alcohol. They should decrease. And finally, treatment options for MAT ALD with dual targets are needed, and I think we have some promising drugs in the horizon, as I mentioned before, with GLP-1 and FGF21. Thank you.